این خانم دکتر جوان ما اولا سکیل دارن توی مایکروسافت آوتلوک، مایکروسافت اکسل، مایکروسافت ورد، اوراکل and farm system و TEFL award دارن. حالا داستانشون که توی یونایتد کینگدوم به دنیا آمدن و خانواده ایرانی و الان یونیورسیتی آف سادرن کالیفرنیا هستن که دکتر آف دنتال سرجری شون دارن میگیرن. می 10 گریجویت میشن. حالا چرا 2 سال بعد اینجا بخونن؟ چون هر کسی که دیگری خارج رو داشته باشه بعد تو امریکا 2 سال یا مثل ما اینترنا که 4-5 سال بعد ادامه بده تا بتونه الیجیبل بشه برای کار اینجا. ولی ایشون قبل از که وارد امریکا بشن توی یونیورسیتی آف سنترال لنکشایر بچلر آف دنتال سرجری شون رو گرفتن و اونجا دنتیست بودن و قبل از اون یونیورسیتی آف ایست انگلیا ماستر این فارماسی گرفته بودن و قبلش هم در ویگستون and کوین الیزابت کالج بچلرشون رو میگرفتن. Obviously she has many awards of سال 2020 Royal College of Surgeon Sirona Regional First Place Winner بودن. British Academy of Cosmetic Dentistry representative بودن و اونجا مدال برانز گرفتن. International Math Award سیلور برانز مدال گرفتن و Duke of Edinburgh سیلور award گرفتن. یعنی سال 2010 همیشه توی کلاسشون بهترین بودن و so she's a pharmacist, dentist and we're very happy to have you here and با آقای بیژن ریزی، دکتر ریزی، پسر دکتر ریزی هوشنگ ریزی ازدواج کردن 2 سال پیش. ما خیلی خوشحالیم که ایشون رو having و این تنها تالنتشون نیست. She has so many more talents که نمیشه بشموری. Lovely lady. راجع به عفونت‌های لثه و اثرش رو الزایمر و بقیه ایمیون سیستم دفعه قبل صحبت کردن که خیلی پاپولار شد و الان راجع به ایمپلنت صحبت میکنن که دیگه الان گرفتاریم. خیلی ممنون سانا جان. جما خوش آمدی. لابی خانم. مرسی بفرمایید.
Thank you so much, Dr. Madani, for an amazing opportunity for us to get together and share knowledge. You always do so much to get everyone together, and you're such an intelligent lady, but thank you so much. I will get to it. I'm just going to share my screen. Give me 1 second.
Sure.
Share screen. Okay, no problem. Okay, so we're going to be talking about dental implants today, and let's go on to it. Oh, that's not. Okay, so outline of today's session, we're going to do an introduction of what we're going to be doing, a history of implants, the rationale behind implants, the advantages and disadvantages, indications and contraindications, and the success and failure. And then last but not least, the patient cases, some interesting cases we can go through today. Okay, so what is an implant? So an implant it's an alloplastic substance. So it's man-made and it's either completely or partially placed into the human body, and it has a use such as a prosthetic use or a diagnostic or a therapeutic. But then when we go into more advanced definition, we have a dental implant. It has a similar definition to this, but instead of it being placed anywhere in your body, it's actually placed inside your mouth, in the oral tissue, beneath the gums and within the bone. And we use this to place a crown or a denture onto this implant screw. Okay, so what are the components? So the main components are is the dental. I don't know if you can see my mouse. Is my mouse moving? Let me see if I can get my mouse to move. Here we go. So the base here, which is the screw, implant screw, and then you have an abutment that gets fixed onto it with a screw there. It attaches it onto this implant, and then the crown is then attached onto the abutment. Normally people call implants, they think the whole fixture here is called an implant. Actually, no, when we refer to an implant, we mean the bottom screw here. And there's different ways of actually placing the crown onto the abutment. It can either be screwed on, or we can use a glue or a cement to put this crown onto it. There's many different sizes of implants, as you can see in the bottom. So depending on how much bone you have in your mouth, where this implant is going to be placed, is it upper, is it lower? Is there a lot of space, little space? That will determine where this, what size implant we will be using. There's many different manufacturers as well that make these screws, and each one has different techniques. Again, the surgeon will decide what size they're going to be using. Okay, so what are the benefits of implants? Most importantly, it's to restore your cosmetic appearance. So if you've got a gap, you want to put a tooth there, and it can close the space. It can also decrease the risk of any decay or any problems you have to adjacent teeth. So for example, in this image here, you can see that there's a space here. The food is more likely to pack behind this tooth here, and because there's a space, and it's very difficult to get to the back of this tooth to clean it. And therefore, normally, if you do have big spaces like this, people will actually, the prognosis of the teeth that are adjacent to the gap are less, and more likely to lose these teeth in the future. So actually placing implants behind these teeth or in these gaps will help make the space cleansable, and helps you reduce any sort of caries or endodontic issues you may have. Another improvement is that the bone maintenance is better in this area, because if there's no teeth in this area and the bone is not being stimulated, you slowly get resorption of the bone and you get recession of the gums. So slowly the bone will decrease in this area, and you can no longer put any sort of implants or even prosthetic teeth, which are dentures, in this area. So putting implants actually allows you to maintain the bone in that area. Placing implants also decreases any sort of sensitivity that your adjacent teeth may have, again, because of the reduced recession of gums. It also, another key factor of implants, and one of the main benefits of implants, is that when you extract teeth, so when you have missing teeth, like in this image here, the teeth at the top, the gravity will start super erupting them. So they start coming down. The power of gravity is immense. So within even a week or 2 weeks of taking those teeth out at the bottom, and if there's no opposing teeth to bite on, these teeth will over erupt, and it can actually cause interferences in eating or even just normal functioning of your mouth. So eventually you will lose the top teeth. It's really important and vital that before you actually have any teeth taken out, and if you have opposing teeth, which will no longer have any sort of occlusion, plan what you're going to be doing with the dentist. So don't just pull teeth out and then think, maybe in 1 year time, I will put an implant in that space, because the likelihood of that is that you'll get super eruption of the opposing teeth, and there will no longer be space for you to put an implant, because those teeth have now taken up the space down here. As we said, it reduces and preserves the jawbone because it reduces any bone loss. Also, another main benefit of dental implants is that it has extremely high success rate, which is over 97% in the first 10 years. So it's a fantastic surgical procedure to enhance your smile. Another integral part of dental implants is that when you're eating, the masticatory forces are extremely high. especially your posterior teeth, your back teeth, if you have any missing teeth, you're going to be chewing with your front teeth. Front teeth are not designed to be chewed on and to eat and put so much forces on them. Just by eating a simple carrot or a piece of meat, you put about 70 to 150 newtons of forces on your teeth. So if you have any teeth missing, and putting implants to distribute any forces will actually enhance the longevity of your other teeth, because any excess forces on teeth will cause fractures, it will cause bone loss, and also you will also wear them away. So it's very crucial to have something to distribute any forces in the mouth when chewing. So let's have a look at the history of implants and where it came from. So about 4,000 years ago in ancient China, they were the first to, it was looked into that they used bamboo to actually produce dental implants. So they carved them and made them look like pegs, and then they inserted them into the mouth. Mainly it was to allow the person to be able to smile and increase a bit of function. They didn't really work very well. They did tend to get infections around them, but that was actually when it first started, that we believe. About 3,000 years ago, in Egypt, ancient Egypt, they used copper and other precious metals, and they made again some pegs, and they would hammer it into the jaw and use them as dental implants. Again, not very successful. In about 2,300 years ago, in France, they saw that they used iron and gold as dental implants. So when they had a look at some of the bodies that they found, they had iron and gold implants in their mouths like this. The gold was used to fix them to other teeth and fix them in that position. They did tend to see that there was there's a lot of bone loss around these pegs and these implants that were used, again identifying that the body obviously was rejecting them in those areas. There was possibly infection being formed because of this as well. Then we go on to about 2,000 years ago, where they saw that the millennials, they actually, what they did when they lost their teeth, they would take animal teeth or any teeth from slaves or any poor people that sold their teeth for really cheap. They'd take them and implant them into the more rich. So they'll take human teeth or animal teeth and just hammer them in to someone's mouth. Again, there was a lot of infection at the time due to this and rejection of these teeth. Then they went on to about 1,350 years ago, where they used seashells, and one of the archaeologists found a jaw, and what was fascinating about it, they saw that there was 3 teeth in this image you can see here. They had actually carved these seashells out of, these teeth out of seashells, and they'd hammered them into the jaw, and actually the bone had started growing around them, which was very fascinating because the body had not rejected them. So that was a big part of the implant history, which was very fascinating. You can see another good image here. These 3 teeth at the front, they're actually seashells, they're not teeth. And you can see the bone has actually scalloped around these, which was extremely fascinating. Then it takes us on to 1965, which was a big date in dental implantology. We have Professor Brandmark. He is was an orthopedic surgeon. He was also a researcher at in Sweden. He found that he used titanium as a material, and he saw that this was biocompatible for dental implants. And he went on to forming these titanium screws, which were very successful. So since he made the dental implants out of titanium, There has been over 7 million implants actually formed by him, and they're still being made. And many other manufacturers have actually started making their own implants as well. But it was one of the first and most successful dental implant materials, which was titanium. So let's look at why he's the father of modern dental implantology and what made him actually realize that this was a fantastic material. So in 1952, he started with the concept of osseointegration. So he wasn't a dentist, he was focused on medicine, and at the Brenmark University in Gothenburg, he started his research. He took a rabbit and he decided to observe the microcirculation within the soft and hard tissues under different injuries on the rabbit. He used an optic chamber and he implanted it in the fibula of the rabbit, and he used the vital microscopic techniques to see if there was any osseointegration around this. So from this, he was when he tried to remove the implant from the implant optic chamber from the fibula of the rabbit, he saw that it was unable to be removed. Therefore, it was an accidental discovery that he realized that there was osseointegration and that the bone had formed around this optic chamber. And this optic chamber was actually titanium, which is very biocompatible. And this technology was actually the start to dental implants. So these are some images that were found. So this implant, this metal titanium implant, was placed into the bone, and you can see that the bone has formed onto the implant itself. On this image here on the right, you can see that there's been some indentation within the bone from the implant, again confirming that has been some osseointegration and bone formation. And at the bottom here, you got electron micrograph of an implant that was placed, and then after 9 months, you can see that the bone has formed through the little indentations on the implant here as well on that area. So it just confirms that there has been successful osseointegration and bone development around these implants. So extremely biocompatible. So if you look at the ultrastructural osseointegration, so what is it and why is it so important? You can see it from this image here on our right. This implant body that's placed down here is embedded into this bone. This yellow part is the bone. You have spongy bone forming at the surface structure there, and you've also got cortical bone. You've only got the soft tissue interface at the top here, which is not in the bone and is next to the gums. And this is basically the abutment that goes onto the screw here. And that's because the reason we have the soft tissue interface here is because there is no bone, and we want to ensure that this area it doesn't cause any irritation to the gum. So it just shows that titanium, the material we use as an abutment, has to be biocompatible and shouldn't cause any irritations to the gum either. So this is the ultrastructure of it. Okay, so there are two theories of integration of the implant. So when the implant is placed, Brenmark said that there's osseointegration, meaning the bone is weaving around the implant and securing it and stabilizing it. There was a second theory found in 1986 by Dr. Weiss. He found that there is another type of integration also involved, and that's called fibro-osseous integration. So it's not only osseointegration. It's dependent on what environment we're in that determines which type of integration is going to occur. So let's start with when the implant is placed into the bone, into the upper jaw, lower jaw, somewhere in the mouth, the area has to heal. So you have primary bone healing and secondary bone healing. When implant is placed correctly with little damage, minimal inflammation occurs, and normal healing period occurs, little inflammation, minimal granulation tissue, the healing process is the correct period of time, and we call it ideal and successful. So the bone over a certain period of time forms around this implant, this titanium, and is correctly osseointegrated. If by any means, when the implant is placed, the healing process is prolonged, it could be that the patient is a smoker, or that they are immunocompromised, or that the method of delivery of the implant was traumatic. So there may have been some necrosis where the bone, where the implant was placed, and there was excess heat generated when the implant was placed into the bone. We then get a more prolonged healing period. We get inflammation around that implant screw of the bone. We get the granulation tissue formation. We get infection. We get fibrocartilage forming. Therefore, because of this prolonged healing process, which we call secondary bone healing, we get, which is undesirable, we get a failure of the implant. So based on these two theories, we can tell whether the implant is going to be successful or unsuccessful. And I'll show you a good image. And this is an image just summarizing how there's so many different factors involved in actually incorporating this titanium implant within the bone, because we're always going to get the trauma, and we're going to get the damage in the area and how well the healing process occurs. And it's a whole pathway of events that occurs here. So let me show you on to the next slide. So we have the fibro integration and the osseointegration. What is the difference? So we have the titanium here, the metal here, the implant, and then we have the bone here. So in between the titanium and the bone, you get that connective tissue. And this is because we have had prolonged healing. We've had granulation tissue forming. We've had damage that's happened. So then, therefore, the bone has slowly been able to form in this area. Therefore, connective tissue fills this area. We call this soft tissue anchorage. So an implant that undergoes fibro integration, meaning the connective tissue is in the interface of it, is actually quite loose. It's not fully stable, and it's not fully integrated into the bone. Whereas osseointegration, in this image, you have the implant body here, the titanium implant, and then the bone forms, and because it undergoes primary healing, which is the best healing process, little inflammation, little damage to the area, and the correct healing of bone has occurred, the bone and titanium meet at this interface, and there is no connective tissue. We have full bony anchorage, and therefore we have complete stability, or the best stability in this area, and therefore this implant cannot be removed. Within fibro integration, if the implant is placed and you have this connective tissue interface between the implant and the bone, you are likely to get infections and inflammation prolonged, eventually causing the failure of this implant. It will not be able to overcome or undertake the load that when you're chewing with this implant, to be able to handle that load. So this implant will move because the connective tissue is just not strong enough to hold it and grip onto it. So the American Association of Implant Dentistry actually defined fibrous integration as tissue, defined it that the interposition of the healthy dense collagen tissue between implant and bone, there is the fibrous tissue in between, so the connective tissue. And if we determine that the fiber integration of the implant has undertaken and not osseointegration, we will call that a failure, and therefore the implant needs to be removed in this sort of scenario. So let's discuss the healing around these dental implants and the endosteel implants. So the implants are placed within the bone. So normal healing period. So there's 4 stages to it. So the first stage is the vascular sprouting stage. So within the first 3 to 7 days when the implant is placed, you have angiogenesis and osteogenesis phase, and that's when the blood vessels are forming, and all the broken blood vessels which are in that area start sprouting and budding, and then you've got the pluripotent cells which are activated. And quite quickly, you get the collagen fibers and fibroblasts, which fill that area, but they are then replaced after that. We then go on to stage 2 of the healing process, which is the early bone formation stage. So it's about 2 weeks after placing the implant by the surgeon. You get more ridge-like bone around the implant surface. You get some sinusoidal capillaries forming. And then some basket-like capillary networks as well, and forming continuous bone. At stage 3 of the healing process, which is about 4 weeks after implantation, you get the proliferation of the new alveolar bone, and then you get trabeculation as well. And then it's the bone growth stage, so you get more and more dense bone in that area. And then we go on to stage 4 of bone maturation. Stage 4 of bone maturation doesn't end. It is continuous. So within about 6 to 8 weeks, the bone is starting to mature. You get capillary plexuses, you get much thicker plates of trabecular bone forming, but that's just the start of bone maturation. We normally say bone maturation really hits its optimal even after 6 months. So you get it's a long process and a long period. So what is it that we can say that we have got successful osseointegration, and what factors are important? Because we want to avoid the fibro integration, we want osseointegration. It's been summarized to be 6 main factors that are integral for the success of the implant and the bone having that full outer surface contact. The implant material biocompatibility. So what material was used? So as we said, Professor Benmark said titanium was very compatible. So depending on what material is used, we can say whether the implant will be successful or not. The implant design characteristics, such as, if you can see on this image here, if it's cylindrical, if it's a straight screw, if it's a conical screw, again, it's really dependent what the surgeon wants to use, and it's different in any sort of patient. It is very case dependent which type of implant is more suitable for that patient. Another important factor would be whether the outside of the implant is going to have a coating. So is it going to be acid etched? Is it going to have some ions there which make the bone grow better around the implant? Is there going to be a biosurface? So that means that there's a layer onto the implant screw which allows for angiogenesis to occur better, and the body won't reject it, less inflammation. Another important part is the host bed. So if you have a patient which has very thin bone, very little bone, a patient that's a smoker, a patient that has a poorly controlled diabetes or any systemic diseases, are they going to be able to handle the healing process? Are they going to heal within the correct period of time for it to be primary healing? If they have immunosuppression or they are immunocompromised, they are on immunocompressive medication, the healing process is inevitably going to be prolonged. So we can automatically tell you that the type of healing that that patient will have is secondary healing, and therefore they will never get osseointegration. That's why it's so important to actually look at every case one by one and get a good medical history of what the patient has, what medication they're on, and what type of bone they have. Another very important part is the surgical considerations. So the surgical considerations is the skill level of the surgeon. How well and how low traumatizing or little traumatizing was the procedure. If a high torque, or we can say high pressure, was placed when the surgeon was placing that implant, that can cause excess inflammation. If a high speed was used when the implant was being placed into the bone, it caused excess heat. Heat can then cause necrosis of the bone in that area. So the implant screws into the bone, but then there's death of the bone in that area. So before any osseointegration can even start happening, the body has to actually clear away the necrotic bone tissue, and that then therefore prolongs the healing process. So again, the surgeon's expertise and level of expertise is extremely important. Also, with surgical considerations, having an in-depth X-ray or techniques they're going to use to see if that bone is even surgically able to have that implant placed. So using various techniques there. A very important one is loading conditions. So when an implant is first placed, we want to minimize any forces placed on the implant. And that's because the more movement this implant has, or the less stable it is, the more inflammation you're going to get around the implant. The more inflammation, we can then determine that there's going to be a slower healing process, a secondary healing. Secondary healing meaning failure of implant, because you're going to have that collagen layer forming around the implant and not the bone. So I actually had a few weeks ago a patient that had an implant placed, and once the implant was placed, his tongue wanted to explore that area. And like anyone, when you have a foreign material in your mouth or anywhere, you want to kind of fiddle with it. So he kept with his tongue pushing. So you can see on this image, this metal top of it's like it's a cap on top of the implant there, so we can locate it. And that's placed for about 3 months. So his tongue kept pushing at this cap, as you can see with my laser. And because those micro movements that formed because of his tongue's movement onto this implant, there was constant inflammation. And therefore, after 3 months, when we reviewed him, the implant was loose. And you can't wait another 3 months and say, oh yes, that's going to suddenly become stable after 3 months and it's going to be better, because the collagen layer forms around the implant and that actually doesn't go away. The implant has to be fully removed and a new implant has to be placed. So that's one of the main reasons why we don't put implants there with a crown on top. So we don't put those the implant with the tooth at the same time. We normally put the implant screw or implant body in first, wait until the osseointegration has occurred and it's fully stable and the bone is fully healed. And that's when we put the crown on top. So when you eat, you put those pressures on. Only in a minimum of 3 months, we can start doing that. So the loading conditions are extremely important. Let's go into a bit more depth about each of these. So implant materials. So as we said, there's many different implant materials that can be used. So we're talking about the screw form here down here. We have metals, which we just discussed, with the titanium, which is extremely successful, 99.75% successful, extremely biocompatible, and is one of the best long-term clinical outcomes have been found with metal titaniums. The other material that there is ceramics. Ceramics, which is here, this white material here, it's like a glass form. Because it's not actually very biocompatible, they actually coat this outer layer of the implant with hydroxyapatite. Hydroxyapatite is a mineral which is biocompatible and your body can accept this material and not reject it. They saw that after 6 years, it actually had 97.8% success rate. After the 6 years, actually that decreased significantly. The main concern they had about these ceramic implants was that the hydroxyapatite coating, which was placed on the outer surface of this implant, actually starts to peel off the implant after a few years. And once it starts to peel or shed away from the implant, it then becomes not compatible with the body, and therefore inflammation starts, macrophage activation occurs, and infections start occurring. So, and then bone resorption. So the bone starts resorbing, and the implant starts becoming loose. That was one of the concerns that ceramics had. The next concern that ceramics had was that after loading of them, so when you're chewing on them and putting those pressures when you're eating on these implants, micro fractures started to form. As you can see on this X-ray, that little micro fracture, and it slowly causes total fracture. So ceramics are more of a glass material, and just like any glass, those micro fractures can then with just one extra force can just cause it to snap. So from this image here, you can see it's caused a fracture of the implant, and it has to be removed surgically. So they're not very good materials, ceramics. The research being done into it to find or research ways that we can make better ceramic materials. But at this moment in time, we can say ceramics are not one of the best implant materials used. Polymers are not used at all, and that's mainly because when they looked at polymer materials for implants, they were rejected. We had a lot of infections with them, and they were not strong enough either. So the main implant material, which is the best, is titanium, and is the most biocompatible. So and osseointegration is the best with this material. So location of implant, where the implant is being placed is very important. So when they had a look and they did some research, it was done in Brazil, and they placed implants in these patients. They saw that the implants were more successful placed in the lower jaw compared to the upper jaw. And the main reason for this was because of the bone quality. Those factors. So you can see that the success rate was extremely high in, so the mandible is the lower jaw, and the upper jaw is the maxilla. You can see that the success rate is still great with both. You got 97%, 98.9%, a few percentage lower for the maxilla, which is the top jaw. The failure was greater with those as well at the top. The reason for this is because the bone quality in your lower jaw is greater. There's more blood supply. There's a better quality bone in this area. And that really highlights the importance of looking at other factors of the patient, such as smoking. When a patient is smoking, we know the actions of nicotine. We went through it last time. Nicotine causes vasoconstriction and inhibits bleeding, and bleeding is very important for the healing to occur. And that is why the quality of bone is really helps us determine whether the implant is going to be successful. I wouldn't say, oh, having an implant in the top jaw is unsuccessful or not as successful, therefore you shouldn't have it. It just helps you understand that how important the vascular system within the bone is important for the healing and for the osseointegration. If a patient had any sort of radiation or chemotherapy as well, this can also cause the vascular system to be diminished, or it can cause increased risk of osteonecrosis in those areas. Again, these are very important factors that the dentist or the surgeon, who are highly skilled to have a look at all these different factors before placing an implant. Patient selection. So this is, again, why it's so important. So you need to have a patient that's ideal for an implant. They need to have extremely good oral hygiene. They should be able to clean around their teeth before we even consider them for an implant, because implants are extremely hard to clean around. If you're not able to clean around your implant, you're going to get that inflammation. The healing will not occur as within the time period we want it to happen, and therefore you have a more prolonged healing time, secondary healing, and rejection of the implant or failure of the implant. How much bone there is in the jaw is extremely important. And to determine this, the oral surgeon or the dentist has to undertake an X-ray called a cone beam CT scan. And you can see it on here, this image here. This is a 3D X-ray of the jawbone, and it's showing you in many different dimensions how much width of bone there is, how much height of bone there is. Not only that, you can also see important anatomical landmarks, such as this orange line here, the nerve. The implantologist, the dentist who is placing this implant, will take a CBCT, can be an X-ray, not only to determine the density, the quality of bone in that area. They can also project on the implant size they're going to use and look at its landmark and orientation to the nerve. This is the lower jaw nerve, as well as sinuses. There has been many times that a dentist may not take an X-ray, a 3D X-ray, and they will impinge onto this nerve here. So if the implant used is too long, it will impinge onto the nerve here and cause damage to the nerve, causing paresthesia of the face in that area. So that's why it's so important having someone who is extremely skilled and appreciates every step of placement of implants and every step of patient selection to determine whether this patient is sufficiently adequate to have implants or not. The general health of the patient is also important. Again, as we said, and I remind again, whether the patient's going to have primary healing or secondary healing is determined by their general health. If they're immunocompromised, if they're on immunocompressive medication, if they have uncontrolled diabetes, all of these will cause a prolonged healing period. So we can automatically say that the secondary healing will occur and we won't get the true osseointegration of implant. Healthy gums, extremely important. We went through gum disease before, and the reason why healthy gums is important is because we want to ensure that there's little inflammation already in that area. So when the implant is placed, the body's not really dealing with the inflammation that was already there, but little bacteria in that area, little inflammation, so the healing can occur much quicker. The patient has to also show that they have regular dental checkups. They are able to attend regular dental checkups and regular cleaning, because it's important that once you place the implant, you can't just neglect the dentist and not go. Actually, in fact, you have to go more often, because you have to make sure that the inflammation is minimal around the area. And if there is any sort of inflammation or any concerns, it can be picked up early on. Within patient selection, age of patient is also semi-important. The older the patient, it doesn't really influence whether an implant is suitable for them. An implant is suitable for all ages. The issue is that the older the patient is, they may have other comorbidities, and therefore the healing process is decreased. Just some few months ago, I placed an implant on a 94-year-old patient and healed very well. Patient didn't have any real concerns about his health, and it healed within sufficient time. So age in that sense is important, but a younger patient that may have genetically dispositioned teeth or missing teeth because of maybe if they have things like ectodermal dysplasia or other sort of syndromes, which causes patients not to have the teeth that they should and are not present, we then decide to put implants in them. But the jaw does develop until a certain age. So we don't want to put an implant in a patient that's too young, because if you place an implant, let's say on a 15-year-old, the jaw is still growing until, let's say, 18 to 21. And if the jaw is still growing, that implant will become displaced. So actually the younger age patients, we are slightly more concerned about placing implants as opposed to the older. Most ages they're suitable for, as long as they're above the age of 20. So whom is a contraindication to put? So we've got the absolute and relative contraindications. the absolute contraindications would be a patient with acute illnesses, or they have a defect or anomaly in within the metabolic disease or uncontrolled metabolic diseases, because the healing cannot occur and they're within the primary healing period, or they have infections that are ongoing. Therefore, they are just not good candidates for implants and they will fail. So we don't like putting implants in those sort of patient groups. Relative contraindications are patients with diabetes. Controlled diabetes, we don't have a concern. It's patients which have more uncontrolled diabetes, because we know with diabetes, healing is impaired and prolonged. So again, we can normally predict that the healing will be much longer than usual, and that we won't normally have the phases of bony healing won't happen in that duration we want it to occur. It may take much longer than the 3 months. It could take even up to a year for the osseointegration to occur, and therefore it normally is skews towards fibro integration in that sense, and the collagen forms. Osteoporosis, again, impaired bone maturation, any parafunctional habits. And what we mean by that is if the patient is a chronic grinder or puts excess forces, we want to actually be concerned about these sort of patient groups, because those extra forces on those implants causes failure as well. Patients with HIV or AIDS, because again, we know these sort of patients have is to do with the white blood cells, CD4 cells that are reduced, and therefore healing is impaired. Patients with bisphosphonates, again, because of that maturation of bone and the bone formation is inhibited. Chemotherapy, which we discussed, and irradiation of the head and neck. These are relative, because if a patient had chemo or radiation to head and neck, maybe let's say a year ago, we wouldn't want to put the implant because we still know that the bone, the high risk of osteonecrosis, a death of the bone that's in that area. But if a patient had radiation to the head and neck, let's say 8 years ago, we can predict and assume that actually they may actually have be better candidates. But this has to be taken into consideration, and we have to really send a med consult to the doctors and just make sure that they are cleared and it's fine to go ahead. Other factors are smokers. Again, we know smoking can inhibit healing. The nicotine is the main factor here, causing vasoconstriction and a delayed healing. The failure of implants are actually twice as much in smokers. So a good oral surgeon or a good dentist who is going to place an implant normally tends to not put an implant in a smoker, because they know it is actually unsuccessful. It's important to recognize this and advise this to the patient, but whether the patient wants to listen and not go ahead is up to them. So in this X-ray above here, we can see that these 3 implants were placed, and you can see that this white area, which is the bone, it should normally be at where my cursor is, where the top of the implant screw is up here. But you can see the shadow, the white line, the white bone is actually at the base of these implants. That means that the bone has actually receded. There is active inflammation, infection possibly, and that these implants are loose. That's because whether osseointegration ever occurred, whether osseointegration occurred correctly or sufficiently, was there adequate compact bone ever formed, and that and also because we have constant inflammation in this area, maybe because of uncontrolled diabetes, the bone has also receded. So there's a multifactorial reason why this patient's at this stage here. The implants are normally quite loose in this stage and they have to be removed. So it's a waste of actually the patient's money to place implants, when we know that eventually in 1 year, 2 years, 3 years down the line, these implants will need to be removed because the bone has just receded down. This image shows that the implant was placed, and then so this tooth is this is actually the implant, and there's actually necrosis of the bone in this area. Whether the implant was placed there wasn't sufficient bone in this area, therefore the implant has penetrated the bone in this area. Whether there's been necrosis, again, many factorial. It could be that the patient may have had radiation and the bone just didn't heal around the implant and caused a necrosis around it. Therefore, it's just very important to look at all these considerations more in depth. So steps in the surgical procedure. So there are normally 4 appointments. When a patient says they want an implant, we arrange them first for assessment and planning. So they come in, we examine their general oral health, their medical health as well, which I've missed out on here. It's just a full exam, not just the oral health. We do a 3D scan, 3D X-ray, a CBCT, to plan whether there's enough bone, whether there is enough space, whether they don't have impingement of any anatomy, such as nerves or sinuses in that area. If that area can even fit an implant, because sometimes drifting of teeth occurs over time and there's no space for an implant. So that's appointment number 1. Appointment number 2, once that's determined, yes, they're good candidates, they come in and we cut the gum, we make a little incision in the gum, and we place the implant in that area. If I just go a slide back, you can see this is the drill here, this line here, this is the water line. We make sure there's water coming out so it doesn't cause too much heat in this area. And the implant, this is the screw, we're just screwing it in ever so slowly into the bone down here. And the reason why it's being done quite slowly is to reduce any heat and therefore any necrosis of the bone in that area. So the implant is placed, and then we wait for healing time for the osseointegration. And that's the longest period you're going to wait. Could be anywhere between 3 months, 6 months, really depends on the patient, the host bed, and where the location it was. If the implant was placed in the upper jaw, we'd wait even longer because we know that the bone quality is not as great as the lower. Therefore, you may even wait 6 months for the top jaw. Lower jaw, 3 months. But the longer you wait, the better, because it becomes way more stable and we can then actually put those forces on and it wouldn't affect the stability because osseointegration has happened adequately. At the 3rd appointment, the patient will come in. So you've got the first appointment, not long after you have the surgical placement, then you wait 3 months or 6 months or however long for the full integration of the implant. If at the 3rd appointment, they notice that, yes, the implant is not moving, is fully stable, they take an X-ray, healing has occurred well, the bone has infiltrated the little grooves on the implant, they then place the abutment. And the abutment is this metal device here, which is screwed onto the implant body. And this allows, basically, the main function of the abutment is for the crown to nicely sit on and lock into it. And once they put the abutment in, they take a mold of the mouth, send it off to the laboratory, and the laboratory does the rest from there. The patient then comes back. Normally, laboratory times can vary 1 week, 2 weeks, sometimes 3 weeks, depending on how busy they are. And they then deliver a crown to us, and we can then attach it onto the abutment. There's different ways of actually attaching this crown onto this abutment, whether you're going to be screwing it on. If you screw it, there's going to be a little screw hole at the top, which we fill later on. Whether you're going to be gluing it onto the abutment. Various different techniques, pros and cons to both of them. Again, it's surgeon preference. We tend to like the more screw retained. So there's a screw hole here and we screw it on, but we like that because when you glue it on, sometimes the glue can leak near the bone and cause inflammation, and we call that cementing. So we don't tend to like that so much. So screwing is normally one of preference, but again, it really is patient dependent and surgeon dependent on what they want to use. And then at the 4th appointment, once the crown is placed, It's just down to yourself to make sure you're cleaning it well and it's a fully functional implant. So the options, so there's various different options. So we have that an option, when are we going to place the implant screw? So we determine that this tooth, for example, needs to be taken out. You can, once at that one point where you remove the tooth, you can place the screw at that same appointment. Again, patient selective, dependent on what the surgeon believes is good. Whether they believe that the patient factors and all the other sorts of factors, the medical history is adequate for osseointegration to sufficiently happen. So we can remove the tooth and place the implant then, pros and cons to that as well. Or when the tooth is removed on that appointment, if we know we're going to be putting an implant sometime after 3 months' time and there's not enough bone, we will put bone in that area. So we'll do a bone graft in that area. On the same day that we take the tooth out, we'll put a bone graft so that it thickens the bone in that area. And then we see the patient 3 to 6 months later to put the screw in. So that's one method of doing it. So we call that alveolar ridge preservation. Another way of doing it is that after 4 to 8, we take the tooth out, 4 to 8 weeks later, we see the patient, and then we place the screw in at that appointment. Another option would be after 3 to 4 months after taking the tooth out. As the time goes by, the bone heals much more. There's more bony healing, more maturation of the bone, and therefore the stability of the implant is greater. So if you wait 6 months, 4 months here, as it says here, and placing it, yes, the bone is better healed. But studies have shown, again, there's pros and cons to all of it, is that when the bone is not fully matured, so placing the implant after 3 to 4 months, where partial bone healing has occurred, is less traumatic and less damage to the bone, and therefore healing is at its optimal, so at partial bone healing. These are all valid options. They all have their own pros and cons, but it just shows you there's so many different ways of placing implant, whether you're going to place it immediately after you take the tooth out, whether you're going to place it months later. When we say implant, we're talking about the screw that goes into the bone. We're not talking about the full crown being placed. That is something that's put on later on. Okay, so what is the benefits to immediate versus the more delayed placement of implants? So clinically and radiographically, they have seen that the bone healing is at its best when delayed placement is undertaken. So when the tooth is taken out, a few months later, the implant is placed. There are advantages to placing immediate implants. There's decreased wait period for the socket to form, there are less appointments, the period of time you'll be without your teeth is less, the cost is cheaper because it's less appointments. You kind of preserve the alveolar bone and the height and width as well, because you don't give it that period for it to shrink. Less patient discomfort. But again, there are obviously quite a lot of pros, but overall, the delayed implant placement is better, and better bone formation has been shown on the X-ray. So osseointegration much greater at delayed healing. So that's delayed placement, sorry. Preferred. So what are risks of implants? The risk of implant is damage to surrounding natural teeth. From this image here, you can see this X-ray. This implant was placed and it's impinged onto the root of the adjacent tooth. This is due to poor planning, incorrect positioning of the surgeon, incorrect technique, surgical technique. They could have made something like a stent, we call it something that guides the implant to the correct location. That would have been down here with my laser marker there. So again, that's a risk that has to be taken into consideration, that they could cause damage to neighboring teeth. There is a risk of sinus perforation, and this is mainly the maxillary, the top jaw issues that with top jaw, and that's why it just confirms why 3D X-rays are important, the cone beam CT scan. This will ensure that the implant being placed is of correct length. So you can see that this here, the implant is being placed and is entering the sinus area here. If it enters the sinus area, it causes infections and it can cause failure of the implant and has to be removed later on. In patients which have large sinuses or small amount of bone between the sinus and this area in the mouth, we can do bone grafting, we can do sinus lifting. Again, that's why it's important to do a lot of good planning with the surgeon, working really well with the operator, working with the operator that's highly skilled at identifying that this patient may need a sinus graft. And not skipping all these important, crucial steps for a successful implant placement. Another risk is fracturing of surrounding jawbone. So if the jawbone, the width of it is too thin, and then an implant is placed, it can cause breakage of the jawbone. Again, this confirms why it's so important to take 3D X-rays before an implant is placed. Abutment screw loosening. This can happen because incorrect loading has occurred, inflammation has occurred, too much pressure on the implant. Implant body failure, which is the screw, we discuss all the reasons why it will fail. It could be patient factors, it could be the surgical technique. Again, that is a risk. Local infection, so the body host may reject it. It will cause inflammation in that area, and the gums will bleed, and the gums will recede, and the bone will recede due to that infection. There is a risk of peri-implantitis, perimucositis, and we will discuss that in a few moments. There is also risk of post-surgical numbness, and that is because if you see that we discussed earlier, this yellow thing here, which is your lower jaw nerve, if a 3D scan is not undertaken, this screw, the implant, may impinge onto this nerve and cause numbness and damage to this nerve. You may have prolonged numbness or numbness that will paresthesia to that face indefinitely. So this image here on your right, this is peri-implantitis. You can see that the bone has receded and the screws of the implant is exposed, and that's a failure. We'll discuss in a second. So what is peri-implant disease? So peri-implant disease, there's two different definitions. So you have peri-implant mucositis, which is the mucosa, the soft tissue, which is inflamed. So if it's peri-implant mucositis is when there's some plaques or some bacteria around the implant, there's some bleeding around it, there's some pain, some swelling, some redness, it's a little pocket there. It's quite reversible if your patient's cleaning it well, visiting their hygienist, we can reverse that, and that's perfectly fine. If we don't identify this early on, it will then progress onto peri-implantitis. This is an inflammatory reaction with the loss of all the bone around the implant. So it's not just the soft tissue, it's the bone. Again, it has the same symptoms as peri-implant mucositis, but it also has some pus, so infection, it swells in that area, and there's pus formation. The implant is quite loose, and when you take an X-ray, we can see that the bone has resorbed significantly and it's exposed. So you can see here on this image here how the bone has receded, the gums have receded, and the implant is now exposed. This is peri-implantitis, and it's a failure of the implant. It's not reversible. We can stop it from getting any worse, but we cannot then allow for bone to form again in that area. So if it's loose, we have to remove the implant, and we cannot stop that. So peri-implantitis isn't so common. It's 5 to 8% of patient cases, and it's mainly to do with patient home care techniques, whether they're cleaning it well or not. And that's why it's so important to get as much advice as you can from your dentist on how to clean your implants and how often you have to visit them. And whether you are at high risk of peri-implantitis is important. So let's have a look at the clinical features. So if a patient comes in and has had an implant placed, there is 3 things the dentist will look at to determine whether you have peri-implantitis. The first of all, we looked at the signs of inflammation. So we said redness, bleeding, pain, inflammation in that area, some pocketing. We will take X-rays here in image B here, you can see an X-ray was taken, the bone has gone down to the base of it. It's no longer at the top, which should have been up here. The bone has receded. There will be some movement and mobility as well. We have had loss of that healing step, and we have the pocketing as well. So these are three things which we will help us determine whether you have this. But the most crucial part is that the X-rays are taken to identify it, but it has to be taken quite right. You can't just place an implant and just forget about it. You do need to visit your dentist, and we will take recall X-rays maybe every year, depending on what your risk factor is, to identify it quite early on. In this sort of case, this implant has to be removed. It's failed. So risk level. So we look at this when placing an implant, we will look at how high of a risk patient you are, or low risk patient you are. If we have a patient that's very motivated with cleaning their mouth, they're really good at brushing their teeth, they don't really have gum disease, they're having 1 or 2 implants, no real medical conditions, we'll say they're low risk patients. Therefore, we may bring them back once a year, at least twice a year, but not more than that. We might take X-rays once a year, sorry. And they're good candidates for implants. Moderate risk patients are ones that are not so motivated. They've got a history of gum disease, teeth are not at its optimal cleanliness, they smoke half a pack of cigarettes a day, they have controlled medical conditions, and they're having 3 to 6 implants placed. We think we will put them in the more moderate risk patient. And what we mean by this is that the risk of them losing the implant or failure of this implant has increased. So it's no longer at 96% success rate, 97% success rate. We are going further down, and there is likely that they will have fibro osseointegration, that sort of patient category. The high risk patients for failure of implant is a patient that's not motivated, doesn't really clean their teeth. They may, when you ask them, they say they brush their teeth maybe once a day, maybe every other day. They've had severe gum disease, periodontitis. They've probably lost the reason why they're getting implants is because they lost their teeth because the teeth were mobile because of gum disease. They need over 6 implants. They've smoked more than half a pack a day, and they're very poorly controlled system. So any of these factors cause the patient to be into more high risk patient, high risk of failure of implants. We want to avoid these patient groups. So how do you prevent peri-implant disease? So brushing your teeth twice a day, soft bristle brush, just like your own teeth, using a toothpaste, brushing under your implant crowns, so making sure you use the interdental brushes, the little ones that you can see in this image here, cleaning really well around them, using the nylon coated ones, flossing daily with unwaxed tape or X-floss, which the dentist may use here to remove any cement, or super floss here, which is expands between the teeth and removes any debris there. Using the oral irrigator, which we discussed last time, or it could be air or water flossing. Seeing your dentist regularly, quit smoking, and really controlling any systemic diseases. So if you are diabetic, seeing your doctor often, making sure you control your sugar levels. So the success criteria of implants are based on 5 things. So whether the implant is mobile, so whether it's moving. So if it's not moving, we can say it's successful. The second thing is that when we do an X-ray, we do not see this gray area. This gray area means that there's inflammation and bone has not formed here. So that's unsuccessful. The third thing we look at is that after 1 year of placing an implant, we should only have a maximum of 1.5 millimeters of bone loss in the first year. Here you can see after a year, you've had, so the bone should have been where the green is, but it's now at the red. That is an advanced amount of bone loss and not 1.5 millimeters. We're talking maybe even 4, maybe pushing on to even 5 millimeters of bone loss there, therefore unsuccessful. After the first year of implant placement, you start getting 0.2 millimeters of bone loss a year is expected. Anything more than 0.2, we'll say that's an unsuccessful implant, and therefore implant will need removing. If the implant has no pain, no infection, no paresthesia of nerve, or damage, or any perforations of the sinuses, we can say again it's successful. So here you can see this image down here. The abutment was placed to the implant, then the abutment, then the crown was placed. So 4 years after loading, you can see you've had a little bit of bone loss there. You can call this successful because you've not had much change in bone in the vertical dimension. So the success rate, we know after 10 years, success rate is 98% of cases are successful. And that means that there's no inflammation, there's no mobility, little bone loss. With bridges, crowns, and root canals, so we're not even talking about implants, their success rate is 80%. So if you go to a dentist and they do a root canal, the maximum success rate for 10 years is 80% for these patients. So actually, the implant success rate is much greater than any other dental procedure we do. With all other medical procedures, any sort of operation you do in a hospital, the 10-year success rate for cumulatively for most operations is 75% success rate after 10 years. This really confirms how amazing implants are, dental implants are, because they have the highest success rate in any sort of surgical procedure with 98% there after 10 years. Not only are they fantastic because their success rate is amazing, if the correct considerations taken, but they also improve the appearance. So if you have a missing tooth at the front here, you can see the implant will improve the appearance there, improves chewing and speaking and eating, the aesthetics, improves the bone and stimulates the jawbone in that area to stop it receding. Looks extremely natural, as you can see here. So amazing devices. So last but not least, just a few cases to just quickly run through. So we're probably running over time. So some cases, so this is case A. You can see that this patient had the history of this patient was that they had a tooth here, they had some trauma. So they caused damage to the tooth, they had some root canal done to the tooth, it failed after a few years, so they had to have it removed. They had a tooth removed, they had a stent made. This stent here will help us guide where the implant screw is going to be placed. So the surgeon can easily just pop the screw into here and just place it into the bone. Therefore, it stops us by incorrectly positioning it at the surgical appointment. 3 months later, we bring the patient back and we see that the implant is not mobile, it's not moving. We make a crown for it, send it to the lab, and we fit it. So this is a beautiful case and a very successful case. And you can see how well matched to her other teeth there is. The gum is fully healed, and you don't see much difference to her other teeth. Case B is a patient that's come in. They had a root canal done. They had a crown previously in this position. They lost the crown. They fractured this tooth. This is their own tooth. When the tooth was taken out, they noticed that the bone is very thin in this area. Therefore, the implant will not have enough space to be put. So what they did at the appointment where they took this tooth out, they placed a bone graft. And because it's the top jaw, and they had a bone graft placed there, they had to wait 6 months for that, 3 to 6 months for that bone graft to really be accepted and fully integrate within that socket area and thicken the bone in that area. They then made and they placed an implant after 6 months and made this device here that allows the gum to nicely heal around the implants to make it more natural. So that's the healing abutment they made in that area. And then they, once they removed it after 6 months of implant placement, you can see that how nicely this tissue, the gum, has healed. And that's when they placed the implant crown on, which is here, and looks a beautiful case here. You can see that the bone and the gums have nicely grown around this implant here. And that's all because the bone graft was done and it was picked up and noticed very early on with a 3D X-ray that this bone is too thin for an implant. So a very highly successful case, beautiful case. Case C, this patient had 3 missing teeth in this area. So it just identifies that we can use implants in so many different cases. Because she had 3 missing teeth in one area, she only really needed 2 implants that were placed. We waited about 6 months for the bone to heal in the area. Again, it's the upper jaw. And at the same point where they put the implants in, they also put the bone graft for better healing, better bone integration. The 3-unit bridge was made, so only 2 of them connect to the implants, and 1 is basically a pontic, which is attached to these abutments, and then it was delivered into the patient. A beautiful case here. So you don't, if you have got 3 missing teeth in one location, doesn't necessarily mean they will need 3 implants. It could just mean 2 implants. Decrease in cost, decrease in trauma, and better outcomes. Case D, you can see that this patient, when they came in, extremely inflamed gums, a lot of bone loss in this area. Teeth were mobile. They removed all the remaining teeth, and they designed a whole smile there. And after designing the smile with wax, they identified where they're going to put the implants in. So you can see the little dots, the holes there. So they're going to put the 6 implants at the bottom, and they're going to put 4 implants at the top here. And then the denture actually pops onto these implants. So these actually this is a removable denture. So in the morning, they pop them onto the implants, and then they take them out at night to clean them. So the takeaway message is that there's a lot of critical factors to be taken into consideration. Where the location of implant is going to be. Is there a sinus there? Is there a nerve there? Is there enough bone there? The patient health, the motivation in cleaning the mouth, the motivation in looking after the implant, the operator skill level. Are they highly skilled? Are they able to identify that radiographs are needed and whether 3D radiographs are needed and how well they're going to analyze these? The material of the implant, the interface of the implant, the continuity of care, so patient attending all the regular checkups, the hygiene appointments to maintain it. They are much harder to maintain than your own natural teeth. So if you've lost your natural teeth because you had gum disease, you had periodontitis, you had mobility or movement of your initial teeth, double think whether implants are a good method for you to restore your teeth, because you can lose them just as you lose your own teeth. Implants are the gold standard method of tooth replacement. Professor Bramark, a very beautiful saying by him is, surround yourself with some of the best minds in your field and you're bound to succeed. So we'll just end it on that mark. Thank you so much for everyone for listening. And I hope you learned at least one thing that you can take away from this presentation. Thank you.
Definitely, Dr. Jannati, Rizi. Very good presentation. Thank you. A little bit scary, but very good presentation. I learned a lot.